Good afternoon. Welcome to the session on medical legal aspects in andrology. It's been a fantastic day so far. We're going to start. First topic is from Frank Chaniwunga, and he's going to tell us about forensic andrology, sexual abuse, the law and the andrologist. Because all the topics are quite separate and distinct from each other, we'll probably have questions after each speaker if there's time. So you can either use your BAUS app and ask a question anonymously, or you can identify yourself and come to a microphone and ask the questions. Frank.
Thank you. First slide up. So forensic andrology, I'm not quite sure why I was given this subject. So I thought I'd do a Google search on forensic andrology and came up with nothing. So what I'm going to talk about is some of the cases that I've been involved with that I think would come under the auspices of forensic andrology. So I'm not sure how many of us are doing work in this area of sexual abuse. It can be quite distressing, can be quite harrowing, some of the details that you hear. And as the expert, you're there to kind of help the court decide is always a man, whether the man is guilty or otherwise. So I thought I'd start with, I'm just going to cover 3 or 4 cases. I thought I'd start by talking about frotterism. Most people know what it is, but may not have recognized the term. So frotterism, it's from the French to rub, and it generally involves men rubbing themselves up against a female in a public place without her consent, for purposes of sexual gratification. It's actually a psychiatric disorder. It's classified as a paraphilia. And the American Psychiatric Association in 2013 have come up with a long definition of what is now frotteristic disorder. And essentially, over the course of 6 months, the man has to exhibit repeated behavior of this nature. So I'll just start with a case of a 40-plus years gentleman who was accused of touching a woman on the tube in an inappropriate manner. So it was a busy London Underground, and over the course of a 25-minute journey, when this gentleman was in close proximity to this woman, the allegation is that for 10 seconds, he made inappropriate contact with her, and she felt that he was masturbating against her shoulder. So she was sat down, and he was standing up, and she said that she could feel his erect penis. Now, at the time, he got off the tube shortly when he thought that she had noticed what he was up to, and then she reported this incident to the transport police, and then 2 months later, when she was on the same tube, she caught sight of this man and was able to get police to arrest him. So he was charged with sexual assault, which is contrary to Section 3 of the Sexual Offences Act 2003. Because he was in a very sensitive job, which I won't go into those details, he lost his job as a result of this allegation. Now, he denied this. He said he was a very respectable gentleman and he would do nothing of the sort. And actually, he had a pouch on his belt, and he said this must have been what this lady was feeling. And he claimed erectile dysfunction. So the reason a urologist or andrologist gets involved in these sexual crime cases is because the man claims that he's impotent. He claims that he cannot get an erection, and therefore he couldn't possibly have done what he has been accused of. And your role as the experts is to assist the court in the likelihood of the man telling the truth or otherwise. So it turns out that this gentleman is diabetic and had been so for a good number of years. So this was confirmed by the GP records. At times you have access to medical records, at times you have access to hospital records, at times it's just the GP records. At times in these cases, you haven't got access to any records, so your history is what the man has told you. Anyway, his GP records confirmed he was diabetic. In addition, he said his job was very stressful, he wasn't sleeping properly, and he had work stresses and so on. Now, he didn't say that he was incapable of getting any erection at all. What he said was that he could get a mild tumescence only, and the only way he could have sex was with his wife on top. The GP had prescribed him sildenafil, so this was verified from the GP records. And in fact, he was on a variety of drugs, not just for diabetes, but also for hypertension and hypercholesterolemia, which we know these are other risk factors for erectile dysfunction. He's married with 2 children. So the questions that were posed were, to me, was how does diabetes affect erectile function? I said, well, there is an association with that. Now, is he capable of attaining an erection? Now, quite often, you can't say whether the man is capable or not of attaining any sort of erection. And even if he may not be capable of attaining an erection in normal circumstances, don't know that he couldn't have taken a pill or an injection or something to achieve an erection in any given circumstance. Is he capable of getting a spontaneous erection? Does he require physical stimulation to become erect? So these were the questions that I was asked to address. So, you know, there's always a discussion about these matters. You turn to the literature to look up the incidence of erectile dysfunction with diabetes, and form some sort of view as to whether with his other comorbidities or not, it's plausible that what this woman was feeling wasn't in fact an erect penis, but was in fact a pouch. So your role isn't to comment on the veracity or otherwise of the man. It's to try and present a dispassionate view as to what the evidence base may be behind it. So your role is to assist the court, and this is quite important because the solicitor who's defending the man is paying your fee. They'll often try and sway you towards a decision in favour of the client, but that's something that you have to resist. In this case, I didn't have to go to court. Well, at least I've not been called as yet. I'm not sure whether this case has been decided or not. The second case of frotterism is a case in which I did have to go to court and stand before the judge and jury and give evidence. So again, it's a crowded train. You know, it's always a crowded train. And interestingly, when I was looking up frotterism and its prevalence, you know, I saw some papers that would imply that 1/3 of men at some stage engage in this sort of behaviour on the trains. I won't ask for a show of hands today, but there is help available. There is help either by drugs or by various psychotherapeutic manoeuvres, which I won't go into. But anyway, in this case, the allegation in this case was that this gentleman thrust his groin against the rear of a woman on a train. And this man, as I said, was over 70, and which is outside the typical age. The typical age is a much younger man, men in 20s to 30s, but this behaviour can be exhibited by men of all ages. Now, this was witnessed by a transport policeman, because that, for reasons which were never clear to me, when this gentleman got onto the train, the transport police thought he was a pickpocket. And so they were watching him and observing him. And what they said was that they saw this man exhibit this behaviour. And the woman also said that she felt, and she was definite that this was an erect penis that she could feel against herself. The gentleman got off the train and in a series of complex manoeuvres, switched 2 or 3 trains before he was finally arrested. And when he was asked why he took such evasive behaviour, he said that he'd had a difficult day at work and he was confused. So anyway, he was arrested. You know, respectable profession. Now, this gentleman had an extensive past medical history of various things that you would associate with erectile dysfunction. He was hypertensive. He'd had 5 years previously to this, he'd had a subtotal colectomy and ileostomy. So the pelvic nerves must have been interfered with. He was on insulin, been diabetic for several years. And he said that he had erectile dysfunction and he's not capable of getting a rigid erection. And that if he took sildenafil, as he had tried on a few occasions, he would perhaps get a 2.5 out of 5 rigidity. But certainly penetration was very difficult for him. After taking sildenafil 2 or 3 times, he stopped because of muscle ache and headaches, and had not sought any other alternative means of achieving erection. And when questioning him about his sexual behaviour, he said that occasionally, he might engage in mutual masturbation with his wife. He was on a long list of medications. He was also on the antidepressant. He hadn't seen a neurologist because he'd kind of given up, he said, in terms of having sex. On examination, he had a stoma. His femoral pulses were present. His distal pulses less noticeable. And he had normal genitalia. And one of the things that came out from the transcripts was that he had his hand beneath his trench coat. In fact, he did have a trench coat. And then his explanation for why his hand was kind of hidden from view was because he was checking the integrity of his stoma. So at times his stoma would come loose, and that's what he was checking for. The police and the prosecution said his hand was beneath his coat because it was on his penis. So when it came to court, there was a lot of discussion with regards to whether he had erectile dysfunction or not, and if so, how severe was it? Was he capable of getting an erection sufficiently that A, the policeman could see it, and B, that someone would be able to feel it through his coat. And he was found guilty of sexual assault and had the commensurate penalties. The other thing to appreciate is that, which I made reference to earlier, is that as the expert, you don't see all the evidence. So I wouldn't see what the lady's claims were. I wouldn't have access necessarily to the police's view. And when it comes to court, you're just in court for the period that you're giving your evidence. So your evidence is in isolation. And so for example, I didn't see the CCTV, which I gather later was quite damning for this gentleman. So it's important to not talk outside your remit and not say whether you think the man is guilty or otherwise, because you don't have access to all the facts. A case from this year, which I think comes under the term forensic andrology, is a middle-aged gentleman who was going from one part of the country to another to visit a sick relative. He got lost. He stopped at a small village, and an elderly lady came by on her bicycle. He wound the window down, and she gave him directions as to which road he should be on. And then he said to me that as he drove away, she started shouting at him in a very loud voice, and he couldn't understand why she was shouting. She reported him to the police and said that while she was giving him directions, he was masturbating, and that she could see his penis. He denied this, and literally 10 days before this was to go to court, his solicitors decided they should get a urological opinion on this. And this is one of the other features in these kind of sexual abuse cases, is why it's always left to the 11th hour before they feel that they should get an expert opinion. So this lady claimed that his penis was out from his jeans, and that she could see it, that it was erect, and it was circumcised, and she could see the gland's penis. So she was quite detailed in her description of what she could see. And he said, well, that's not possible because I've not been circumcised, number one. I've got a phimosis, and it's not possible to retract my foreskin. So therefore, this discredits her allegation that I was doing what she accused me of doing. And furthermore, my penis is of such a size that if it was outside my genes, she wouldn't be able to see it. So I was asked to give an opinion on certain matters. Number one, was he circumcised, as this lady had claimed? And I said he wasn't circumcised on examination. Does he have a phimosis? Can the glands be exposed? And this man had a very tight phimosis, and it was physically not possible to retract his foreskin. I was asked to give a grading as to the severity of his phimosis. I don't normally grade these things. If a man has a phimosis, he's got a phimosis, and we do a circumcision on him. So I looked to see how do you grade degrees of phimosis, and came across a pediatric paper from 1993, which graded the phimosis as to how far you could retract it and whether you could see the meatus or not. 0 would be you could fully retract the foreskin. 5 would be absolutely no retraction. So I said his phimosis was a score of 3, but you certainly could not retract it that you could see the gland's penis. So it came to court. I wasn't required in court, but the judge dismissed this very, very, very quickly and directed the jury to acquit this gentleman on the basis that her evidence wasn't credible because she could not have seen his gland's penis. And so his legal team sent me an email thanking me for my assistance in this case, as indeed the man did. I wasn't quite sure that I was comfortable with that, but as long as you stick to the facts and you give your honest and true opinion, that's what you're required to do. I'm not sure how many urologists do undertake this, sexual abuse work. I know one or two of you do, because I've done joint statements with one or two of you. But it's very difficult for solicitors to find urologists or andrologists willing to undertake this work. It's not like if you're on the taxi rank as a taxi driver, you have to take the first punter that comes along. And with this type of work, you can turn it down, and many do. So it's difficult for solicitors to find people to kind of do this work. And this was a case a few years ago. This was a gentleman that I was asked to visit in prison. This was a prison up north, and I work down south. For those of you who've been into prisons, they're very rigid institutions. It's very difficult to fit a time that you can actually see a client. And I've certainly been on prison visits before where I've been waiting for a guard to accompany me. It's then running to lunchtime, and so nothing can happen until lunch is over. So you sit there for another hour and a half until lunch is over before someone can escort you in. So logistically, it's very difficult to organise getting into a prison. So I saw this gentleman about a few years back now. Now this gentleman had been convicted, so he was in prison he was in jail for digital penetration, oral penetration, inappropriate touching, and consensual intercourse, but with a vulnerable adult. And he appealed against his sentence, and the basis of his appeal was erectile dysfunction. Now, this gentleman said he had never had penetrative intercourse, and the children that he did have were by intrauterine insemination. And in fact, there was evidence that this was how his 3 children had been born. He'd come from overseas and had settled in the UK. And why was he impotent? Because he said he had a road traffic accident, which was verified by the medical notes from overseas. Road traffic accident, pelvic injury, urethral injury, and first time when he tried to have sex, which was in the end of the 80s, it wasn't possible. And in fact, there's documentation of 2 suicide attempts that he had made because of his erectile dysfunction. Tried Viagra, which failed. Came across to the UK in 2009. GP had prescribed him sildenafil, which didn't work. He'd been referred to a urologist because of erectile dysfunction and also a stricture. Now, one of the claims that had been made against him was that he had had intercourse with 2 vulnerable women. He was a care worker, and he'd gone into this care home for the first time, which is a care home for women with various mental impairments, not capable of living independently. But it wasn't a psychiatric home. It was a kind of an intermediate facility, and he was the only one on that night. And he said that when he arrived, he had to supervise these ladies cooking and having their evening meal, and they were talking about sexual matters. A couple of these ladies said that they were lesbians, and did he want to watch them engage in this behavior, and he declined. And then he said he went into the office, and at 9 o'clock he had to give them their various medications. And 2 of these women came into his room and were into the office and were behaving to him in an inappropriate fashion, and he kind of told them off and dismissed them. He then says that later on he went to his room that he'd been allocated for the night, and when he went to his room, which he thought was meant to be locked, there were these 2 women in a state of undress, and he said that he was going to report them. He told them he was going to report them for being in his room, which is an not authorized visit. And they said that if he reported them, then he would be in serious trouble. They would make all sorts of allegations against him. So come the next morning, in these care homes, you're meant to give a report to the permanent member of staff as to what's happened throughout the night. And he didn't mention any of these encounters that he'd had with these ladies. He didn't mention the fact that he'd found them in his room. He didn't mention the fact that they had keys so they could access all areas. A month later, he's arrested by the police, and he's accused of these sexual crimes. Now, one of the things that I think did for him in terms of being convicted was that he didn't mention at any stage to his solicitors or to the courts that he had erectile dysfunction. And when he was asked why I asked him, why didn't you mention that? He said it was a source of shame to him, it was a source of embarrassment. And because there was no forensic evidence linking him to having sex with these ladies, he didn't think in his wildest dreams that he would actually be convicted. So this went to appeal, and I went through all his medical history and his medical records, and it seemed plausible that what he was saying was indeed true. I found it very difficult to believe, with all that extensive history, and he'd had all kinds of surgeries in his perineum and his urethra and so on. I found it difficult to believe that someone who allegedly never had sex before could have had sex twice in 10 minutes. Of course, I couldn't comment upon the touching allegations, but I could say that I thought it unlikely that he would have been able to do what it was claimed. However, he lost his appeal, and I think the reason he lost his appeal was the court said all that medical evidence that's come to light subsequently, it may all be very true, but you should have brought that up at your initial trial. So this gentleman is still in prison. There are a variety of other sexual misdemeanors and cases that I don't know how I'm doing for time. Yeah, I need to round up. So these are just a selection of cases where you're asked to give an opinion on very difficult matters. So, for example, a gentleman claimed that on an army base, when he was drunk, he was sexually assaulted by another soldier, and that this other soldier put his penis into his mouth, and that the other soldier forcibly put his penis into his rectum and caused him to ejaculate. And all the questions that I was asked to try and give some sort of opinion on were: if you were drunk, could you get an erection? If you really didn't want this to happen, could you be so drunk that you'd have an erection but you wouldn't be aware of what was going on? Is it possible for someone to put your penis into their rectum against your wishes? And is it possible to ejaculate if you don't want to, and if it's causing you distress? Very difficult to answer these kind of questions, but you have to come to some sort of opinion. Another case I was involved in, this was a Ministry of Defence case. A prisoner said that he was tortured to his scrotum and therefore had developed erectile dysfunction. Another case was this gentleman was found naked in someone else's house, naked from the waist down. He has no recollection of how he entered this house. The owner of the house grapples with him, wrestles with him, and holds him until the police come. The owner of the house says this gentleman had an erect penis, and I think he was wanting to come and assault sexually members of my household. So again, the questions that arose in court was: if you're that drunk that you can't remember leaving the nightclub to waking up in the police station, is it possible for you to have an erection when you're that drunk? And this gentleman, who was the defendant, said that he can't recollect anything at all. But when he's touched in his groins or in his back, he's got all these funny erogenous zones, and when he's touched anywhere, he could get an erection. And therefore, he thinks the reason he had an erection when he was grappling with this gentleman wasn't for sexual purposes. It's because when he's touched in these places, he gets an erection. Anyway, to cut a long story short, this went to court, and the jury couldn't make a determination. So, in summary, forensic andrology, in my experience, has been almost exclusively matters of a sexual nature, where you, as the expert, are asked to try and give an opinion to help the court decide whether the man is telling the truth or not. Thank you.
Thanks, Frank. That was very, very interesting. Do you think there's a reason why people don't want to do this sort of work?
There's lots of very good reasons.
Are there any questions from the floor? Just time for one quick question. Okay, there's nobody submitted a question. Frank, do you think there's a wasted opportunity, as much as doctors we are trained to assess and verify people's stories and how genuine we think they are, and yet you're specifically told not to make any judgment about whether, your view on whether somebody's defendant's guilty or not?
Yes, well, we aren't taught about that at all in medical school or in our higher training either. I suspect it's only a few that would wish to kind of get involved in the legal processes. Yeah, so it's not for everyone, I guess.
Okay, thanks very much.
Okay, our next speakers are present. Mark Speakman, who's going to talk about issues around testicular torsion, who should be doing it and where the surgery should be done. Mark.
Thank you. Can we have the next set of slides, please? Thanks. Good. Thank you, Ian. Thank you, Duncan. This is the topic I was asked to address, so I'm not going to give you a lecture on torsion as a generality, but try and concentrate on these two things. Who should manage torsion and where should it be managed? And I was sitting in my office at home thinking a few weeks ago where to start. And basically, can we have the next slide? The next button doesn't seem to be working. If we could have the next slide, that'd be great, thanks. Excellent. And I looked above the desk I was sitting at, and there was my Bailey and Love's textbook of general surgery. Those of you who've got as much grey hair as me will know this was the textbook we bought at the end of medical school years and took through us into SHO years. So I thought, well, let's open that and have a look. Well, the first thing I noticed was I actually bought the book in November 77, which is when I took 6 weeks out of medical school and did the conjoint exams in London. And I went through this, noticed I'd paid £17.50 for the book, and took out of it one important sentence. Urgent exploration of the scrotum is indicated. That fact, I think, guides us to decide who needs the operation and where. A much more modern idea, this is Nick Rukin and his colleagues' excellent BAUS Urological Emergencies app. He stresses the same thing. Urgent exploration because, as we know, delay may result in the loss of the testicle. And Nick gives some figures for the likelihood of loss depending on how long the child, because they're typically childs or young adults, has had a torsion. I then looked at Campbell-Walsh, the newest edition. Same factor, testicular torsion is a true surgical emergency. But look at the next comment, which is interesting. Somebody's obviously thought this through and put it in the latest version of Campbell-Walsh. Institutional transfer should be kept to a minimum. And that really caught my eye. And the reason it caught my eye was I was aware of 3 medical legal cases, one on the west coast of Scotland, one in mid Wales, and one on the south coast, where young adults or children were transferred long distances, in my opinion anyway, inappropriately, and as a result lost their testicles. And when I met with the medical leads of both the MDU and the MPS in the last 12 months and mentioned this, they clearly know of more cases than this. So it is a hot topic within medical legal thought processes at the moment. If you look, this is the 2014 list of cases from the MDU. On the front page was one on testicular torsion. This was a post-sports injury. A child had been playing football, may or may not have been kicked playing football. Therefore, both the GP and the casualty officer who saw the child thought it must be trauma, not torsion. Obviously, it turned out to be torsion. And one interesting comment, which is a recurring theme in medical legal things, if you make good records, you have a much better chance of winning the day and carrying the case. So everything in medical legal things always goes back to the quality of the records. 2 more cases, both for children with single testicles. And one on the left from the MDU was a child who'd lost a testicle because of an unsuccessful orchidopexy when he was very young. The one on the right, which is an MPS one, is actually more interesting still. This was a 14-year-old boy who went to casualty with a very good history of testicular torsion. But 4 years earlier, this child had lost a testicle because of torsion. Testicle had been removed. So when they went back 4 years later at the age of 14, the casualty officer said, there's no way you could have a torsion because it would have been fixed when you had the operation. But in reality, they did not have access to that. So the child was sent home from A&E, came back a few days later, and you've guessed it, it was clearly a torsion. And both the casualty officer and the original surgeon both got sued because when they did find the records, he apparently hadn't done it. And very importantly, hadn't told the family and the child what had or hadn't been done. So there's areas here of concern. This is interesting. This is an American case, and this is making the statement basically that unless you can give a really, really good alternative diagnosis, then you've got to presume it's the torsion. Investigation doesn't add much. If in doubt, we should be exploring them. And they're making the statement here that the commonest reason an American urologist gets a lawsuit is because of testicular torsion. GPs, even more likely to be sued and successfully sued. On average, a lot of urologists will get off because they will have acted reasonably. On average, though, most GPs, when they get sued, lose the case because there is example of delay, and this is one of the top causes of GPs being sued. So the question for us is, if you hold a CCT, a Certificate of Completion of Training, should you be able to do a torsion? Because the 3 cases that I gave you, where those 3 cases are occurring in Scotland, Wales and the South Coast, in each of these, one a urologist and another a general surgeon and the third one an anaesthetist said, I do not have an elective paediatric practice, therefore I cannot do the operation, and therefore transferred the child a long distance. And yet, within ISCP, it clearly says that the management of patients with scrotal swelling and the treatment of testicular torsion is an accepted thing you must have achieved to get your CCT at level 4. And when you look at the curriculum in more detail, it breaks it down quite clearly. At ST1-2, you're supposed to have level 2 competence, which basically means you can do the operation with supervision. But by ST3 to ST6, the expectation is that you can do it in straightforward and complex cases. So in reality, anybody we give a CCT to should be able to do a testicular torsion. This document, a very good document, and our own Paul Jones from Swansea put the Neurological Input into it. This is the English College of Surgeons Standards for Non-Specialist Emergency Surgical Care of Children. And it's basically saying that if you call yourself a consultant, you should have the skills to do it in a local secondary care hospital. And as a result, you should bear this in mind in your CPD and collect the data on those cases for your annual appraisal. This is part of the document. It's not terribly easy to read the slide, but it's highlighting here these cases are urgent, and one of the things they involve in this document is the acute scrotum or the management of testicular torsion. This statement says all consultant surgeons and anaesthetists providing emergency care in a district general hospital should have the skills to manage common paediatric surgical emergencies, which clearly includes torsion. This is also within the document, and this sets out the pathway. The only excuse in reality is if you do not have the correct local facilities. And what this document stresses is correct local facilities basically mean you have the right paediatric ward care and paediatric nurses, you have the right theatre availability and recovery availability for children. It's a given that the consultants involved should have the required skills. And this was part of the statement that I wrote in the last President's newsletter that went out to the BAUS membership. And the English College of Surgeons had read it, and they then republished it in the Children's Surgical Forum in this way. Now, I made one mistake in that, because I said I'd talked to the MDU and the MPS, which is true. I'd talked to their medical leads, and I said, if you transferred a child a long distance, you would not be supported. And they correctly pointed out they would be supported, but probably unsuccessfully. So I believe the answer to this question is that when a child comes in, anybody over the age of 5 who has an acute scrotum, they should be seen first by a junior doctor, an F1, F2, or possibly a CT1. They should then be reviewed by a registrar, and that does not matter whether it's urological, general surgical, or in a paediatric hospital, a paediatric registrar. But then a consultant should be informed, again, whether it's a urologist, a paediatric surgeon, or a general surgeon, and that consultant should get involved if the registrar does not have the training or skills to do it. So if I get called at night by a general surgical registrar, says, oh, I'm really sorry, Mr. Speakman, I don't know how to deal with a torsion. I said, that's fine, line it up for theatre, I'm coming in, you're doing it, and I'm going to supervise you. In other words, we've got to train them. In most DGHs in this country, it's general surgical registrars who see it, supervised by consultant urologists. In some hospitals, like Plymouth and Exeter until recently, it was general surgeons and general surgeons. In most of the teaching hospitals in the UK, it's urological registrars reporting to urological consultants. But at the end of the day, it's actually the medical director's legal responsibility to believe that they have a system in place that is sound and effective for their hospital. So I believe that the statement we should be putting out jointly from the MDU, MPS and BAUS is that it would be difficult to defend the actions of a consultant who referred a child a considerable distance if the facilities for local treatment were available. That it's the medical director's responsibility to check that's true, and if it isn't achievable, they need really rapid processes to move these children quickly. The key factors, as I say, are basically the nurses, the theatre, and the recovery. And it should not be an issue with consultant urologists, general surgeons, or anaesthetists that they have or have not got the skills. Their CCT in each of those specialties says they should be able to manage the non-specialist emergency surgery in children. Your thoughts? Thank you very much.
Thank you, Mark. Any questions? I see. It's, microphone 1, please.
Thank you very much. It's a great summary. I mean, I think the cat's thrown amongst pigeons, because last week there was a GMC case where a general surgeon got struck off, where he attempted to take an epididymal cyst, took off a testicle, and they deemed it as it wasn't within his remit of his surgical skills. Now, it is possible that general surgery trainees and even consultants may say, look, we haven't done this for a while because we had support from a urology service which has now been relocated because of amalgamation between 2 units, etc., that we can't do this. So what do you suggest that they do in that situation? Because we can't force them to do it if they feel that they haven't had adequate training.
Yeah. No, you're absolutely right, Asif. At the end of the day, I go back to the key principle. That is, it's the medical director's responsibility to have a system in place. The fact that that person may not have been exposed to that for some time is an issue really for CPD and training. In other words, each hospital has to have a viable rota that can deliver what it has to deliver. If they cannot do it, then they have to have rapid transfer. So if you're in a sizable city where there's a paediatric hospital, it's quite easy. But if you're in Aberystwyth or somewhere, you have to have a local system because it's just too far to send people. So I agree it is tricky, but this is not difficult surgery at the end of the day, and we should have the skills to deliver it in reality.
Microphone 3, please.
I completely agree with the surgical component of it, but the anaesthetics are a big component of it as well. We're very lucky where I work in Watford that we've got very good anaesthetic support, but lots of other hospitals, it depends which way the wind's blowing as to where an anaesthetist is going to do the case or not.
Well, that's a fair point, but the truth is the anaesthetic CCT suggests that the management of children over the age of either 4 or 5 should be within the realms of somebody who calls themselves a consultant. So if they've got to deliver acute appendicitis and other things, they should be able to deal with torsions. I spent a long time talking to the president of the British Association of Paediatric Surgeons, and they felt that it should be 4 or 5. They were a little bit split. I think children under the age of 4 probably should only be dealt with of people who do children all the time. But the incidence of torsion in the under 5s is so low that it's not really going to be an issue. I know there's a neonatal group, but they're pretty much lost testicles anyway. So in reality, practically, if we say above 5, that will probably encompass 90-odd% of all the torsions. But you're right, one of those 3 cases was an anaesthetist who said they didn't have the skills. Well, according to the medical defence unions, they would support somebody who didn't have an elective practice in paediatric surgery doing it as an emergency because the expectation is they do have the skills to do it. If they don't, that's a CPD training issue.
Microphone 1.
Mr. Speakman, I think you just really answered that question, because I was going to ask you about the under the age of 5. I know it's rare, but you're now saying you'd be supported if you transferred someone under the age of 5.
Yeah. Because the probability that the delay is crucial in that group is pretty low. I mean, the idea is that the under 5 should only be operated on locally if it really is life or limb to a very high level. And I think the likelihood of torsion in the under 5s is probably sufficiently low. So, I mean, there's a few people like myself who do have an elective paediatric practice. Okay, not particularly complex stuff, but we are operating on young children all the time, and I'm lucky enough to have predominantly anaesthetists who can deal with it. But the assumption is that these rules should apply to the over 5s, because that's a safe thing to expect people to be able to do.
And I think microphone 4.
So the question is related to our general surgical colleagues who may wish to provide or should be providing the service for units that don't have urology cover overnight. Part of the award of the CCT is demonstration of core competencies, and in their surgical curriculum, they have to have, they're questioned on it, it's part of the exam, but in the training that they get, they don't often get exposed to it. No. Now, I work in a central unit in a tertiary center, and the peripheral hospitals may have a general surgeon who's recently been appointed who blatantly says he's not been exposed and doesn't feel competent. Now, I can understand that would relate and require engagement with their medical director for that, but as BAUS, as urologists, are we engaging with the general surgical colleagues who award CCTs, and it's not just based on the questions or the exam, but also their exposure to torsions?
Yeah. I mean, the important part of that question was your caveat at the beginning, if it was a hospital that didn't have urological cover, because if it did, then we have to be bold enough to say this is a urological condition and we've got to cover those surgical registrars. But if they genuinely didn't have it, then that would be a decision for a medical director to decide how it would be achieved. But at the moment, their core training for general surgeons includes level 2 cover for torsion. Recently, they took it out of the higher level, but they're in the process of putting that back in. And Ian Eardley's leading this project to look more closely at what emergency general surgeons should be delivering. So I think that'll come back on the agenda. But I think you've hit on a key problem there, and that is there are a few younger general surgical appointments who say they can't do it. And at the moment, their CCT isn't specific enough. So there may be a small group there, but at the end of the day, it's the medical director's responsibility.
Microphone 2, Julian.
The loss of one testicle is bad. The loss of 2 testicles is a
Massive.
catastrophe. And I'm dealing with a medical legal case in which a 17-year-old has lost both testicles, and of course, leaving him in the most awful position for the rest of his life. And I think I agree entirely with what you say, but the one issue is it's always late diagnosis or failure of diagnosis, blaming the condition, the swelling on orchitis or whatever, which is always invariably wrong. So one really ought to reiterate this issue that if you see a swollen testicle in anybody under the age of 25, unless there's a good indication that there's infection, which is usually unusual, they should be operated upon. But it doesn't happen. And that's what's bringing these cases regularly to my door and to yours, I'm sure. And I think we need to go back and ensure that everybody's trained to realize if there's a swollen testicle, you're better off operating on it than not.
And the final question is microphone 3.
Mark, thanks very much. And I think this is a very hot topic we are facing in our hospital as well. And I kind of sympathize with both the viewpoints. I have a very big elective pediatric practice as well, so I don't have a problem with this at all. Few of my colleagues, and we have become so super specialized now, and I'm talking of few of the oncosurgeons who just do oncosurgery for last 10, 15 years. They have nothing to do with pediatrics at all. And they do feel uncomfortable doing pediatric torsions as part of the rota. And we have mentioned about the CPD. Now, I think we can just elaborate a little bit more as to what CPD would be required. If we all take this view as a consensus statement that all consultant urologists should be dealing with pediatric torsions full stop, that can come out as a consensus statement. Then we need to work through what is CPD is required for those who have an elective practice which has got nothing to do with pediatrics, and they feel uncomfortable dealing with children because they have not dealt with children for 10 years, 15 years. I think we just need to explore that side of things as well to help these people out.
Sure. It's a very fair point, that. I mean, in the really big hospitals, it might be that rather like the radiologists now have 2 tiers of on-call for interventional radiology and the regular radiology. They may have to look at that, but in truth, we have to have a system in every hospital that's safe and effective. But you make a very good point.
Okay, thank you very much, Mark. Thanks for the talk, and thank everybody for the questions.
Next, we have Raj Nigam, who's going to tell us about the pitfalls of vasectomy and frame this within the implications of the new guidelines. Raj.
Thank you very much, Mrs. Chairman. I've been given this talk really to outline some of the new guidelines that have appeared for British workers in essence. But I will cover some medico-legal aspects of vasectomy. It is obviously a hot topic and has been for a number of years in the medico-legal world. Vasectomy is on the decline. This is not just in the UK, but in many other countries as well. The British Pregnancy Advisory Service bemoaned this fact and said that it had dropped from about 37,000 in the early 2000s down to about 15,000. They called these findings disappointing. Some people may agree with them, others would say just desserts for this particular operation. The actual data support this. We can see that there's been a gradual decline in the number of vasectomies performed, at least in the NHS. This data combines HES data as well as that gained from community clinics where a lot of vasectomies are now performed. It does not show private data. There is no adequate collection of this. There may have been a slight incline of private vasectomies, but there's no great evidence to support that. This appears quite often in the media. The BBC gives a very accurate version of what is going on, but the Mail decides to have a go at men in terms of making their decision, saying that husbands are refusing to make the ultimate commitment because they're now too selfish. There may be some truth in that, but it's a multifactorial process as to why men are no longer choosing vasectomy as their primary contraception option. It's got to the fact where there's now promotion of this particular operation going on. Just very recently, in Men's Health Week, the Murray Stopes organisation decided to give a press release whereby they tried to aim at the fans and supporters of the rugby and the football that is going on to encourage men to consider having a vasectomy in the run-up to the UEFA Euro 2000. Whether they were mindful of the fact that there was going to be quite a lot of violence later on, I don't know. George Clooney got on the bandwagon as well and decided to tell the world that he was going to have a vasectomy and didn't want to have any children. And again, this sort of thing goes round the social media circle quite a lot. So in the UK, where are these vasectomies being performed in the NHS? We know that still the vast majority are actually performed in hospitals, although this number is declining. 2014-15, the latest statistics show that there were only about 8,600 vasectomies performed as day case. The data collection has improved such that they're now recording vasectomy as a secondary procedure as well as a primary procedure. For the last few years, it had only been recorded if it was the main operation. But we know that there are a fair number of cases whereby it's a secondary procedure that is carried out at the time of another operation, usually in the genital or scrotal region. Community clinics are still performing between 4,000 and 5,000 cases a year, and there are some that are recorded as inpatients. Why are the reasons for the decline? Well, one of them may well be a decrease in NHS availability. We know that there are a number of CCGs who do not refer or sanction referral to hospitals and would refer some to local community clinics where there is usually a very, very long waiting list. There are about 120,000 divorces a year in the UK. Men perhaps are becoming mindful of this, that they may get divorced one day and they do not want to be out of the market in terms of getting another partner who may wish to have further children. There is widespread media coverage of the complications of vasectomy. With social media and so on, things get tweeted and retweeted time and time again with graphic pictures of what has gone on and people's experiences of the procedure. And as you'll see shortly, celebrities have got involved with this as well. But also is the fact that long-acting, reversible contraceptives have increased significantly in women. So use of the intrauterine device, intrauterine coils, and also implants has increased considerably from about 18% as a primary choice for women to 31%. It should also be noted that female sterilization has declined considerably at the same time. So from about 40,000 cases about 15 to 20 years ago, it's now gone down to about 14,000. So surgery seems to be waning for sterilization or for contraception. These are just some of the things that I found, just on a very basic search on vasectomy and what is being promoted and what is being said about vasectomy. You'll see on the right there, Jamie Oliver, the Telegraph reported 11 things you needed to know about vasectomies Most of them were negative, including why Jamie Oliver was right to be scared. He didn't have one in the end. So how does this translate into litigation? We're all aware that vasectomy is a highly litigious procedure and probably ranks much higher than one would expect in terms of the procedures that we carry out as to the number of legal cases that are created from it. If one looks at the whole of litigation in urology, and this is a freedom of information request that I did from the NHS over the last 5 years, we see that there is about a slight incline, up to about 6 million last year, and these are completed cases. There will be others in the pipeline. The grand total is about 27.5 million that has been paid out in urological litigation. We should put this into perspective in that the NHS pays about 1.2 billion in total. So we do rank relatively high, but not as high as some other more obvious specialties. What about specific vasectomy litigation? And you'll see here that there were 36 claims that they received in the last 5 years, but only 19 of them were successful and reached closure, totaling 363,000. Now, that may not seem like a huge sum in the overall amount, but as you'll see later, there are set case law which has determined this and has brought that figure down. However, there are exceptions to this, and I'll discuss one or two of those cases. Certain recent settlements, which one of my lawyer colleagues told me about, there is a legal database that all lawyers can submit their cases to. It's meant to be confidential in terms of quantum, as to how much is actually gained from that particular case. So you can see that failed vasectomy, a failure to sterilize, seems to be coming out fairly frequently, acute stress and pain, and loss of a testicle following vasectomy. This was a case where, which has been highlighted by the website of those particular lawyers that fought for that case, in which the man developed a very severe hematoma. He had been told by a nurse who had seen him previously that he should probably have a general anesthetic. The surgeon, who was a GP, said no, he would proceed under a local anesthetic. He found a very short, tight scrotum, struggled, thought he had got the VAS, but it turned out that he hadn't got the VAS on that side. Huge hematoma developed, infection, and subsequent necrosis, leading to the loss of that testicle. And that settled for the sum of 9,000. Each organ in the body, as you're probably aware, has a set value in legal terms. This case was also highlighted in the media and is now quoted as constituting case law. This was up in Scotland. Daniel Stalker had sought a vasectomy after he'd had his fourth child. That vasectomy failed. Carried out by a general practitioner who did not make adequate notes. The patient developed chronic bilateral testicular pain, and 2 years down the line, he had been through the gamut of treatments and interventions for his chronic pain, and eventually had both of his testicles removed. He subsequently sought £1 million in damages. The judge found in his favour and did not make the full award, but the message here is that the surgeon originally performing it was heavily criticized. And he said, on a consideration of the whole evidence on this point, I find that the pursuer suffered neuropathic pain. When Dr. D inserted an instrument into an unanesthetized part of his scrotum in the course of blunt dissection during the attempted vasectomy procedure. The procedure here had been abandoned, he had written a misleading letter to the GP, and had not completed the operation note. He could not have forgotten what had happened in that case. This case changed a lot of preceding laws. 1999, McFarlane versus the Tayside Health Board. He'd sought a vasectomy after 4 children, had 2 semen samples, which were reported as negative, or at least he received a letter stating that they were negative. He had a 5th child, and the couple sought £100,000 in terms of bringing up the child and £10,000 for pain and suffering suffered by the wife. It was initially dismissed, but the Court of Appeal awarded damages for pain and suffering and the costs of bringing up the child. The defendant, however, went further and went to the highest court and went to the House of Lords. The appeal was overturned and the economic loss was dismissed. Subsequent to McFarlane, case law has deemed it that if you have a healthy child, that the economic costs of that child cannot be claimed. Prior to this, there were extremely interesting cases whereby parents who had become parents following a failed vasectomy had sought damages insofar as bringing up the child until they were 18. In terms of, there's a case where public school education was paid for up until the age of 17. And there are several stories like that prior to McFarlane. So McFarlane was a key case where the House of Lords ruled. Parkinson was a different case, but again has made case law. This was a case of failed female sterilization. However, it has been shown now that this is applicable to male sterilization. Angela Parkinson had, it seems to be 4 and 5 children all the time, had 4 children. She'd had a sterilization, not wanting any further. That female sterilization failed, and a disabled child was born. During the course of the pregnancy, they were aware of the disability, but they chose not to have the termination. Damages were awarded in this case, contrary to McFarlane, because of the costs related to the increasing charges for the disability. The judge ruled here that the purpose of the operation had been to prevent further children being born, including those with congenital abnormalities, and the surgeon's duty of care was strictly related to that purpose. So here we had normal adult but with disabled child, and Parkinson's is a clear case whereby the parents can claim if a disabled child is born. This has been argued in a lot of legal circles, and not all lawyers agree with this ruling, insofar as that the surgeon could not have been aware that as a result of his negligence that a disabled child would be born. However, this case law holds. And the final case that is now part of case law is that of Karina Rees versus the Darlington Memorial Hospital. Again, a failed female sterilization. On this occasion, she had retinitis pigmentosa and did not wish to have any children because her blindness was progressing and she felt to be able to bring up any further children. The judge in this case said that the majority decision appears to be founded on a view that claimants are entitled to an award which is not compensatory for any particular loss or damage because the child was healthy, but to reflect the law's acceptance that the victim of the negligence has suffered a legal wrong and has been coerced into parenthood by that wrong. He awarded a maximum award of £15,000. That figure has now held to this day, insofar as, due to a failed sterilization, if the parents have a healthy child, that is the maximum that they can claim. So specific pitfalls of the operation. I'm not going to go into too much detail of the operation. I'm not teaching grandmothers to suck eggs. Everybody here has been taught, who is a urologist, how to carry out a competent vasectomy. However, it's important to know where the pitfalls are and where the legal issues come in. So I'm going to break this down into the preoperative, the operative, and the postoperative pitfalls. The main obvious one preoperatively is around consent and informed consent. It's very important to discuss the actual procedure that you are going to do, the complications that can be expected, and the post-operative instructions. You need to explain these, you need to record these, and you need to copy that to the patient. As Mark Speakman had said, that in medico-legal circles, the documentation is so vitally important. It's important to examine the patient beforehand and offer alternative means of anesthesia if they are required. Clive Gingell wrote many, many years ago on this subject, and he said there was no shame to turn around to the patient and say, I cannot do this procedure on you under a local anesthetic. If you've got a short, tight scrotum, the patient is jumping away from you when you're just approaching to examine him, you can imagine what he'll be like with a needle. So don't get involved in lunchtime vasectomies, which happen in certain places, where you just go there, see the patient half an hour beforehand, and then do the procedure. Examine them beforehand and decide what would be the right mode of anesthesia for that patient. There is a very important document. You may or may not believe in the BAUS procedure-specific consent forms, but this is one where I would commend it to you. It is a 7-page document with an area for signature by the patient at the end. It affords some legal protection as you have given them validated information. It does not, however, replace proper counselling, and it does not replace making a proper documented record of the preoperative discussion. And this was produced in March 2016. The operative pitfalls, as I've said earlier, select the appropriate mode of anesthesia. Technique, obviously, is very important, which I'll come on to. I would always argue you should make bilateral incisions, but there are a lot of community clinic vasectomies that are carried out through a single midline incision. Excision, ligation or diathermy, and fascial interposition are all important factors. The failure rate without interposition has been as high as 6 out of 1,000, and there are plenty of other papers which support fascial interposition. Always have a complete operative record. The techniques, there's no absolute as to which way is the only way to do it. You can divide and excise, or you can just divide and ligate. You can section and do cautery. You can do cautery alone, but fascial interposition seems to be very important. Some people have even advocated doing an open-ended vasectomy because there's less chronic scrotal pain. There have been some papers supporting that, but the risks of recanalization, are very high. Whichever method you choose, it's important to record exactly what you have done. And just a special mention on hematoma. This is the one thing that people see straight away and obviously afterwards. This is how they gauge whether their vasectomy has been successful or not. If you're offering them a scrotal support, write it down that you've asked them to wear one and for how long. If they develop a hematoma, give them antibiotics. It has been an open wound, and therefore there is a risk of infection. Prompt drainage if it's required. We've all had to explore these from time to time. We often don't find a bleeding point. But if you've got a huge hematoma, there's a risk of an abscess, then explore. You can always be accused of an act of omission, but if you've done something to try and prevent it, then the law courts will look upon you favorably. Always provide a point of access. It's very, very important that you can say, contact this number, attend casualty, or whatever, if you develop a large hematoma. And continue to follow the patient up until resolution. Post-operatively, like I said, you give them that advice. Post-vasectomy semen analysis I'll come on to shortly. And always give them advice about failure of sterilization. They can get earlier failures and they can get late failures. Early failures were recognized a long time ago and published in the BJU in 1969. Late recanalization appeared in Tim Phillips' paper, seminal paper in 1984, and other papers have concluded the same. It's about 1 in 2 to 1 in 3,000 for late recanalization, and those are the figures that are quoted on the BAUS leaflet. Clive Gingell wrote this a few years ago. Why are doctors sued post-vasectomy? Some of these we've already discussed. The failure of the procedure resulting in unwanted pregnancy, significant postoperative hematoma plus or minus infection requiring operative intervention. There is a case report of Fournier's gangrene following a significant hematoma after vasectomy and a death following that Fournier's gangrene. Chronic scrotal pain requiring further surgery. Again, you must warn your patient about that. Atrophy or loss of testicles, sometimes following the above. I mentioned a couple of cases already where that has happened. And failure to inform patient of a positive post-vasectomy semen analysis. And this is what I'll come on to shortly. Documentation, I've said, is so important. And the lawyers often quote this, Joyce versus Merton, Sutton and Wandsworth Health Authority, where the judge said, sometimes a professional man who is accused of malpractice may only be able to defend himself by referring to what is his normal practice and stating his belief that he did not depart from his normal practice on the occasion in question. If the documentary evidence does not show that proper practices were followed on that occasion, then the weight that can be given to such evidence must be limited. It is a truism that even competent and experienced practitioners can, on occasion, make careless errors. I.e., if you haven't documented it, you haven't done it. This is again the vasectomy leaflet on the left, but also there is a leaflet also produced by BAUS, which gives advice on post-vasectomy sperm counts. So that again, one can give to the patient following the procedure. So what are the new guidelines? The British British Andrology Society had published guidelines way back in 2002. This is the first conjoint guidelines produced by the Association of Biomedical Scientists in Andrology, the British Andrology Society, and BAUS. I would commend these guidelines to you, not only because they are comprehensive, but also because about 3 times within these guidelines when I read them, I read the words medico-legal consequences if these are not followed. So the lawyers will pore over this document, and therefore it's very important that we're all aware of them, but also we need to pass this on to the laboratories that are carrying out our semen analyses. And I'll touch on that why. These guidelines cover a number of areas, but they cover scheduling of the post-vasectomy semen analyses, how to collect those, the specimen containers, the collection and the receipt of samples in the laboratory, and whether it should be on-site production, which is what is recommended, or off-site production but kept at body temperature.
Raj, can we
wind up? Yeah. So they state that 4 hours should be the maximum time for evaluation to say whether there's sperm or no sperm. 1 hour, however, if you're looking for motile or non-motile sperm. Postal and courier transport is no longer sanctioned, where it was acceptable in the 2002 guidelines. And the medico-legal consequences of these guidelines are very important. The clinician is still responsible for imparting the information to the patient. The timing is very important. Essentially, 80% of azoospermic men are azoospermic after 20 ejaculations, and men with an ejaculatory frequency of less than 3 times a week take 5 weeks longer to achieve azoospermia. So not just the number of weeks, the ejaculatory frequency is important. Minimum of, these are our guidelines, minimum of 12 weeks and 20 ejaculations, examine within 4 hours, and a single sample is now deemed to be sufficient if no sperm are observed. Special clearance can only be given if less than 100,000 per mil. Comparing to other guidelines, they do concur with a lot of these. So the AUA says between 8 and 16 weeks. All of them say 1 sample is sufficient. I think we'll end it there.
Okay. Thanks so much, Raj. In the interest of time, I think we better move on to our next speaker.
Okay, our final speaker in this session is Julian Shaw, who's going to talk to us about surgery in the penis, some cautionary tales.
Mr. Chairman, ladies and gentlemen, this topic is very important, isn't it? All this aspect of genitalia, we men are very attached to our genitalia, and no more than the penis. We certainly don't want anything to go wrong with it, and yet things do, especially in relationship to surgery, and something that we need as part of our remit as surgeons to try to avoid. If you go to Harley Street, you'll see this car. It's quite amazing, Bentley. If you've got a sore tooth, it'll drive you to a dentist. So I think if you want to come back as anything, come back as a dentist. When patients undergo surgery, they expect a Rolls-Royce service. And I think this applies to everything that we do. And I think this is something that's becoming increasingly difficult for us, isn't it? We're under enormous pressures to try to produce excellent results under great time pressures with the amount of work that's being put upon us. And I think it's becoming very, very difficult for us all. When you're dealing with penile surgery, the patient wants a good outcome with the resolution of the primary problem with no loss of function and loss of sensation. So I think it's something that is a very hard act to achieve for any of us. Consent's been mentioned, and I think the issue of consent is very important. And even though you may say to a patient after the event, well, you would have had it done anyway, which is true about many things that we do. I describe in teaching, there are 2 indications for surgery, relative and absolute. You have a black leg, you saw it off, you have to do it. But many things that we do are relatively necessary, they're not life-threatening. And therefore, if you think that your competence is not up to it, it's far better to refer to somebody else who can do it competently than take the challenge yourself. And when you're discussing consent, of course, you need to discuss the indications. Why you're doing this, the patient will know, but you still have to go over it. The benefits, in other words, why you're trying to do the procedure and what you're going to achieve from it, and the complications that may occur. Now, the BAUS information sheets have been mentioned previously, and I believe that they are very, very important. An enormous amount of work has gone in to BAUS information sheets. And this is the one, you can't read the typing very well, but nevertheless, it's for penile prosthetics. And in that information sheet will be all the aspects of that particular surgical procedure and the complications. But I recommend not only do you download them and use them, but you should read them. Okay? And I don't think we do we? So we may download them, but we may not necessarily read them. And the same thing applies for operations for Peyronie's disease, very elegantly covered, including the complications. But I'm going to mention a complication at the end which is not put in one of the BAUS guidelines, which I think should be included. And I think if you see things in the guidelines that you find are not there that you would like to see, then you ought to advise BAUS so they can include them. One of the operations that does take place is ritual circumcision. And you may or may not be asked to do this. I certainly have in my career done some ritual circumcisions, but many years ago. And circumcision in hospital will be scrutinized in the same manner if it's ritual or whether it's not ritual. And you need to show that your practice is reasonable as judged by your peers. And the other issue that's being discussed and has been discussed on many occasions is whether ritual circumcision is consistent with the child's best interest. And of course, it could be argued philosophically that it cannot possibly be so because the child cannot consent. There's a duty to treat complications. So if the patient has had surgery outside of the hospital, usually by a non-registered medical practitioner, and the complications arise, it is your duty to ensure that those complications are treated, such as bleeding or necrosis or inadequate circumcision, which may occur. And in fact, there are situations where some medical practitioners have deregistered themselves so they can do ritual circumcision for reward, of course. Because if they are not registered, they cannot be struck off if things go wrong, although they can be convicted if there is a negligence act. What operations do we do that carry a risk of litigation on the penis? Of course, the one at the top of the list is circumcision. I'll talk about that in a second. Of course, Peyronie's surgery, where a patient has a bent penis, that is an operation, and I'm sure you've discussed it on many occasions, that is not always perfect in producing the best outcome. What you want is a straight penis without loss of length. Do you get straight penis without loss of length with Peyronie's surgery? Almost invariably not. With penile implant surgery, if it goes well, it's great, but if it goes badly, it's awful. And certainly there's an interest in penile enhancements and lengthening surgery, which I wouldn't recommend anybody to do unless they are mad. Venous leak surgery is now out of fashion, and I've not included urethroplasty as part of this. In my own medical legal experience, I do see patients referred by lawyers with complications of genital surgery. And the ones in the recent past that I've come across have been a patient who was catheterized and developed a priapism, and that priapism was not appropriately treated. So had the patient been referred appropriately, then he would have had treatment, which not necessarily would have achieved the outcome that was expected, but it certainly didn't in his case. Fournier's gangrene I'll mention in a minute. We're dealing with a case in our own trust where one of my registrars did a circumcision on a patient and didn't take enough skin as perceived by the patient. And I had to redo the surgery about 6 weeks later. And the patient is suing us because we did not take enough foreskin, so he still had an overhang of skin, and he is very dissatisfied. Interestingly enough, the man had been in prison. I seem to get a few prisoners suing us. And the question was whether or not the registrar who did the surgery had not taken enough skin and whether it would be criticized. Interestingly, the expert chosen to defend our trust said there was no fault in what went on, because circumcision doesn't always necessarily guarantee to remove all the foreskin. Let's talk about that in a second. Of course, a patient may complain of post-circumcision pain, and who is responsible for that? That may not be anybody's responsibility. It's bad luck, like after vasectomy. One thing you have to be aware of is that urethral catheters cause urethral injury. So nobody should have a long-term urethral catheter beyond a week or two unless there is a very good reason for it. I had a patient come who had a spinal cord injury, who had a urethral catheter in. His penis is cleaved from tit to bottom. And that took place under the very eyes of his treating doctors. And nobody's offered him reconstruction until he saw me as a medical expert, and he's now become one of our patients, so we're about to reconstruct him. So things can be avoided by knowing about the complications. Trauma can cause penile injury. Certainly, trauma can cause Peyronie's disease. One thing I would caution you about when you write in your own notes, not medico-legally, but clinically, is making conclusions about the causes of conditions if you're not sure. I've seen many cases with, for instance, who have been said they have neuropathic bladders when they don't have neuropathic bladders. Be very careful about mentioning diagnoses when you're not sure of the diagnosis. And that may apply to Peyronie's. Of course, if you get a direct penile injury, it's straightforward enough. Laceration of the genitalia is straightforward enough. I have a patient who has a shortened penis as a consequence of a pelvic injury, and it's due to scarring of the suspensory ligament. And of course, I've seen a Prince Albert injury where the patient was on a motorbike and his penis was ripped by the Prince Albert being caught. Penile trauma can be a bit deceptive. This young boy was injured in a car accident, but when his foreskin is retracted, you can see how the glans has been very majorly damaged by that injury. One of the most important things about surgery, I believe, is that a knowledge of the complications improves the chance of not having complications. Of course, it's easy for me to say I've lived a long time, I've operated upon many patients, and I've seen complications of my own surgery. But knowing about the complications often helps you not get complications. Gynecologists won't cut ureters if they know where the ureter is, or if they cut it, they know how to recognize it. It's because they don't know that they get the complication. And the same thing applies with penile surgery. So an integral part of training should be an understanding of the complications, and then you won't get the complications as much. And also it enhances the consent process. The other issue I think is very important, which you benefit from in private practice, but you don't in the NHS. In private practice, you see your patients, you look after your patients, there's continuity of care. You see them soon after they're discharged. I see all my patients at 2 weeks after surgery. Therefore, I know what happens 2 weeks after surgery. However, in the NHS, we are told you've got to send them home as soon as possible. And you then can't see them for many weeks because of the pressure on your clinics. And that means you don't really know what's happening in the patient's recovery phase. And the patient wants to know that. How can you say when they should return to work, when they should take exercise? You don't know those things because you don't see them for very long periods of time. And therefore, follow-up and careful follow-up is very important in your ability to learn about management. As a good example, if you see your patient who's had a penile prosthesis and you don't see them for 6 weeks, the bruising has got better. But after a week, it's very bruised and the patient's very worried. So a knowledge of late complications improves the treatment of the primary condition. Fournier has been mentioned, and Fournier's gangrene is a catastrophic condition. Often it's not necessarily preventable, but I've seen several cases from circumcision where infection has not been recognized nor treated expeditiously, and then the patient ends up with a catastrophic event which leads to major loss of skin, provided they don't die. Luckily, these patients didn't. But if the patient loses skin and split skin grafting takes place, the penis does not expand with erection. And in these pictures, you can see how much skin can be lost. And although you may say, well, that's a good cosmetic appearance, it's not a good functional appearance. And the only way to reconstruct these is with full-thickness skin grafts, and they need to be done by experts such as Sachs and David Ralph and those experienced in this field. Circumcision is one of the most important operations that we can undertake, and it shouldn't be delegated to the most junior person. Often these things have been in the past. And so it's, I believe, one of the most difficult operations to do well, to create a good cosmetic outcome, without taking off too much skin and without leaving too much skin. And I think that is something that you have to learn by experience, by training, and by supervision, and it's something that we need to do very carefully in our program of training. If you don't achieve what the patient expects, then they will be distressed. And patients will take action against you if they feel that you've taken too much skin, and that will undoubtedly be found against you. So I've seen several cases where too much skin's been taken, the patient can't get a decent erection, they've been skin grafted with split skin thickness grafts, and the penis is unable to stretch and it's painful. And that will undoubtedly be found against you. Leaving too much skin is not necessarily a problem as long as you explain it to the patient beforehand, but obviously you've got to try to get the balance between too much and too little. The one thing I wanted to mention, which I started off by saying at the beginning, is compartment syndrome. Compartment syndrome can occur in penile surgery. If you've got your patient up in stirrups for long periods of time, then vascular insufficiency will occur and the patient will get compartment syndrome. This occurs more commonly after cystectomy, and it can occur after radical prostatectomy, but it's not included in the BAUS consent form for cystectomy. And if your operation is a prolonged operation, in my view, if you're doing a cystectomy, there's absolutely no reason why the patient's legs should stay up for 7 hours, which I think is far too long for any operation. It's never taken me longer than 3 hours to do a cystectomy diversion. But if the patient's legs are up, they should be put down after you've done with the access to the perineum, because all you do is increase the risk of compartment syndrome, which is a preventable complication largely. If you want to avoid a complaint, whether it's with penile surgery or any other form of surgery, the most important thing is kindness and compassion, careful consenting, and careful surgery. Contemporaneous notes which are comprehensive, you cannot write enough. Take photographs
I know you have to have permission these days. You can't use your iPhone, but keep a camera in the theatre, make sure that everybody's consented for photographs, and take photographs. They will help you. And if you have a complication which you are concerned about, you don't know whether it will lead to litigation, and it could take many years for it to do so, but write a contemporaneous record. You don't necessarily need to file it in the notes. You can keep it at home, but have it there in case you ever have to come back and make a statement. I've seen situations where a registrar has written, I remember quite distinctly what happened, and it was 7 years previously. That can't be true. If you get a complaint, of course, engage with your trust or your protection society if it's a private patient. Become involved with the process. The more you are involved with the process, the more likely you are to get an outcome that is satisfactory. Prepare a chronology of the events from the case records. I was talking to somebody earlier on about there are cases being taken against him. He didn't know who the expert was going to be. I would say get involved in your choice of expert. Don't let somebody choose an expert who may be too inexperienced, not in the field, who maybe you don't like. You want somebody who's going to be helpful on your side. As an expert, I do a lot of expert work, and yes, I will have enemies because I will criticize some people. If you made a mistake, accept it. There's nothing wrong with that. We discuss any complication that we have at UCLH at MDT. It's openly discussed in front of 20 consultants, and we will be quite critical. There's nothing wrong with that. You can learn from the process. The problem with medical negligence is that often the system does not learn from the process. You often don't have feedback either from the lawyers or the trust as to what has happened. That is wrong. The only way to learn about these things is to be in the middle of it. And I think if you do ever have a case taken against you, which pretty well all of you will, I certainly have, the more you're involved, the more you will learn. Disseminate it. Don't be afraid. We've all made mistakes. I can tell you some shocking stories from my own career. Everybody can. And if you've got a good boss, he'll always stand by you. Learn from the process. Thank you.
Thank you very much, Julian. We are out of time, I'm afraid, so no time for questions. Thank you very much to all our speakers this afternoon. Thank you particularly for the questions that we had time for, which was an interesting discussion.